Good afternoon. My name is Kamran Mirza, and I am one of the Virtual Pathology Grand Rounds committee members. On behalf of the American Society of Clinical Pathology and all of our committee, it is my pleasure to welcome you to today's ASCP Virtual Pathology Grand Rounds. As for housekeeping, a link to our Obtain the CME will be posted in the chat. Please enter your questions you may have in the Q&A tab at the bottom, and feel free to introduce yourselves and say hello in the chat feature as well. We are delighted to host Dr. Alia Hussain as today's speaker, and I have the distinct honor of introducing her today. My colleague and co-committee member, Dr. Elham Khanafshar, will be moderating the question and answer session at the end. Dr. Hussain was my beloved program director, so this is doubly special for me. She is a professor of pathology at the University of Chicago, where she serves as the fellowship director for the Thoracic and Surgical Pathology Fellowship and the co-director of the integrated M2 pathology course at Pritzker School of Medicine. She is an internationally recognized pathologist, most well known for her expertise in thoracic and pediatric pathology. Dr. Hussain completed her medical education from King Edward Medical College in Lahore, Pakistan, followed by pathology residency and surgical pathology fellowship at Loyola University Medical Center. She started her career as faculty at Loyola, moving to the University of Chicago in 2004. Dr. Hussain is a champion of pathology. She has coordinated several dozen national and international meetings, workshops, and courses, and serves on the editorial board of Archives of Pathology and Laboratory Medicine, where she is the section editor for pediatric pathology. She is actively funded on numerous research projects, but most notable is her work on mesothelioma and lung transplantation. Her CV boasts over 50 book chapters, 100 invited presentations, and over 200 publications. She is also the editor on 11 pathology books, many of which are behind me in my office as well. Dr. Hussain is a beloved educator and internationally recognized pathologist. She has been voted favorite faculty at Pritzker School of Medicine several dozen times and was inducted to the Alpha Omega Alpha Medical Honor Society as a faculty honoree there. She is a lifetime member of the Master of Academy of Distinguished Medical Educators at the Pritzker School of Medicine, and also was a recent recipient of the Lifetime Achievement Award from the Chicago Pathology Society. Today, Dr. Hussain will be sharing some pearls of wisdom on the topic of thoracic frozen sections. Please join me in welcoming Dr. Hussain.
Thank you, Kamran. That was very, very nice. Actually, you have me in tears because of how much we have shared over the years. Yeah. So as you may know, I have known Kamran was one of the residents here, and then the 1 year that I didn't have a fellow, he served both as the chief resident and did my fellowship to help me out, and I really do appreciate that. And I hope that you've, some of the cases here might have been from the time that you were here. So I'm happy to talk about thoracic frozen sections. I've been doing these for over 30 years now, and I hope to share some of the things that I've actually learned, things that are practical, things that the surgeons are asking the questions for, and that what is the key feature questions to answer during a frozen section. So this is what I want to begin with, is that really you have to know what is the frozen section being done for. You must read either the clinical history or what the specimen will be sent and what is identified on the specimen as being the key. Is it a margin? Is it a diagnosis? Is it just benign malignant, or do they want you to triage the tissue? And this can be, is listed here. There are multiple reasons for doing a frozen section or an intraoperative consultation, however you may want to call it. And these are the various reasons. And I'm going to show you a number of examples from all of these questions. Okay, so starting out with the University of Chicago, where I have been now for almost 20 years, with the COVID times, the masks are appropriate. I will start with the first topic is when there's a lung nodule. So again, you should really know that it is for a nodule, because how you interpret a specimen or how you even section it depends on whether you're doing it for a nodule or for an interstitial lung disease, for example, or for an infection or in an immunocompromised host or not. So the most common frozen that we get for lung is a nodule. And I think the most common question that they have, at least in our institution, is it benign or malignant? And this is usually done on a wedge biopsy, but you might have other biopsies for it as well. And I'll show you a couple of examples of that. So once you've decided that it's malignant, they do want to know, is it small or non-small? Although I think this is not as critical anymore, because if it is a small enough lesion that they are doing a frozen section because they want to do a primary resection of that lobe or segment, then even if it is a small cell carcinoma, they should really take it out because that's the best treatment for a small sized small cell carcinoma. Primary or metastatic is also a key question and not always easy to answer. But I think the main thing to remember for primary or metastatic is that if you have a central scar, you should be thinking of a primary tumor. If there is no scar, the morphology has to fit. Otherwise, you cannot really be sure. If you're not sure, it's best to say that because you don't want them to do a large resection for a metastatic tumor. They can always go back another day if they need to do it. But I think now with the more aggressive sort of workup before taking the patient to surgery, we are seeing less of these questions. The vast majority of the time, in my experience, the surgeon has already done a biopsy of some kind and then are taking them to surgery. But it still happens. I think I would say every 2 or 3 months, we get this question of primary versus metastatic. Then you do get questions about whether is it resectable or not, meaning how far is it going? And I'll show you an example of that. Margins are key. You have to remember that the pleura is not a margin, but involvement of the pleura by tumor is a staging issue. So when you take a section, don't go over the top, the closest point of the pleura, rather than you should take a section into the specimen at a tangent or away from the closest point. Lymph nodes are really straightforward in this setting. Do they have malignancy or not? Because that is part of the staging. And if you call a lymph node positive, they will stop the surgery and not do a lobectomy if this is a mediastinal lymph node. They usually don't send hilar lymph nodes for frozens because hilar lymph nodes are considered resectable with the tumor. So these will be mediastinal. Do remember that other things can also happen. You can have a patient with a cancer and a granuloma, or a cancer, a carcinoma in the lung, and CLL maybe in the lymph node. So always in the back of your mind, don't just jump to the one diagnosis. Make sure that you've looked around and said, what else is there? And then, is there a mediastinal mass or not? Sometimes it's not just for a lung nodule, but for a mediastinal mass, and I will come to that in a minute. In the pleura, the question usually is, again, benign or malignant in a patient who has had pleural effusions or recurrent pleural effusions or has a mass. This also often is done on a cytology prior to the surgery or on a biopsy, but occasionally there are patients whom they've not been able to do that or because of the clinical indications, they take them straight to surgery. And the question, is it benign or malignant, is sometimes a difficult question. They do occasionally ask if you think that this is a mesothelioma or metastatic tumor, and I'll show you a couple of examples, but this is not easy to say. I think for them to plan their surgery on a frozen section differential between mesothelioma or metastatic carcinoma is not a fair dilemma to put the pathologist in, because as you know, even for permanent sections, we need so many immunos to differentiate between mesothelioma or carcinoma that doing it on frozen would be very difficult. All right, so starting off with the first wedge biopsy that you get for a nodule. Here is one in which you can appreciate the pleural surface. Part of it has been inked. Here, actually, I think this is, it doesn't look like a wedge. I think this is a lobectomy because I see mediastinal hilar structures here, sorry. And there is a clipped edge, because even in a lobectomy, they have to clip where it is attached or closest to the other lobes. So you will have a surgical, that is a true surgical margin. The pleura is not, but when you cut into it, that's what this knife is showing, is not to cut where the tumor comes closest to the pleura, because that section you need for your permanent section for staging. So you want to cut away from that and then take one representative section. So one of the questions I get asked also is, how big a nodule should it be before you freeze it? My general response is that if it is less than 1 centimeter, it is not a good idea to freeze it. You can do a touch prep because it will distort the specimen so much that you may not have a good section for permanent. Certainly less than 0.7 or 0.8 centimeters, I try not to do a frozen. I do talk to the surgeon and say, what would you do differently? Because if it's that small, then a segmentectomy may be adequate resection, whether it's benign or malignant. So the size does matter of the tumor for doing a frozen. So if they do insist that you do it, only freeze half the specimen and not all of it, because you want to save some for better morphology. But so that's it for the nodule. We almost always get margins of the bronchial margin for a frozen section. It is really important not to just look at the lumen or the epithelial part, but also look at the connective tissue outside, because tumor can be growing outside in the soft tissues. That is also a margin. And that takes some explanation for the surgeon, because they think that, oh, they got plenty of margin, that they see nothing in the lumen. But you have to explain, if you're going to call that margin positive, that there is tumor growing in the connective tissue. That also is a margin around it. All right, so starting out with a few cases. The first case, 1A, is a 68-year-old male with a right lung mass. An endobronchial biopsy is sent for frozen. So this is a very unusual circumstance, because typically we don't get endobronchial biopsies for frozen section. And surgeons usually will do a bronchoscopy before they start the lobectomy, in order to make sure that there is no extension of the tumor, especially if the primary tumor is a little bit larger, to make sure that it is not extending into the main bronchus or the trachea. So the biopsy, if they do send you that and you know that that is the question they are asking, it's appropriate to do a frozen. Because most of the time, the vast majority of bronchial, endobronchial or tracheal biopsies, we don't do for frozen. Those are for permanence in the general practice. So the second one is a 60-year-old female with a mediastinal mass, and before attempting to resect the mass, they did a bronchoscopy and similarly sent an endobronchial biopsy for frozen. So these are straightforward. These are patients who you think you know that they have big masses and they want to see the extent of the tumor. In the upper left, you see that it is clearly a carcinoma, or at least clearly malignant. It turned out to be a squamous cell carcinoma, but you don't need to have to say that. You just need to say, this is carcinoma. And the bottom right shows you a small cell carcinoma, which was the mediastinal mass, which was second extension of the tumor into the mediastinum, really, and up into the bronchus. So this was considered unresectable. So that is one indication for doing frozen sections, is how far has the tumor extended. So this will show this. The first case shows, the two first cases show you that. For case 2, a 61-year-old female with a lung mass, a needle biopsy is sent for frozen. So now this is also an unusual scenario to have a needle biopsy sent. But we will still, so my philosophy is that when the surgeon is in the OR, I don't argue with them. If they ask for a frozen on a needle biopsy, I'll do it. And then I'll give them my best possible interpretation, saying, based on the limited amount of tissue, this is what I think. You may want to send me another biopsy or 2 or 3 more cores. And so I don't ever refuse to do a frozen generally. You know, I shouldn't say ever or generally. Bad language. But generally, I will do what the surgeon is asking, and then discuss it with them afterwards. Tumor board is a great time to bring up these issues so that everybody is aware of what are the limitations of a frozen section and what kind of specimens are ideally suited for it. So this time, though, the issue was they just wanted to know if this was tumor or not. And with the needle biopsy was surprisingly very good, even though there was so much inflammation in the background. But clearly there are clusters of malignant cells, and they were very happy with getting that diagnosis, just to say that, yes, you can appreciate that here, that this is carcinoma. And then they did do a lobectomy in this patient and they also send the lymph nodes for frozen that were benign. So unusual core needle biopsy, but can be done. So the most typical specimen that we get is a wedge resection, though, for frozen. And we see this at least once or twice a week. And everybody should be comfortable looking at lung frozens because it's just such a common cancer or common scenario to have these tumors and to have frozen sections from them. So 1.1 centimeter size. So that would be just about appropriate to do a frozen, and we took a piece and looked at it. So this is also, the frozen section turns out to be unusual. The scenario is not unusual, but appreciate how cellular this tumor is, and on high power, the cells are crowded. There are apoptotic cell nuclei that you can appreciate, maybe even mitotic figures. They're not projecting as well, but certainly this was a small cell carcinoma. Oh, here, large areas of necrosis. You don't have to say on frozen anymore, I think, whether it's small or non-small, as I said, because the size is so small that if you had just called this carcinoma or positive for malignancy, that would be good enough, which is how this case was reported. Because you can't always be 100% sure that it's not a lymphoma on a frozen section, but there is some rosetting maybe here, some here. So if you call it carcinoma, if you call it small cell carcinoma, is fine. My philosophy is give them just the answer to their question. You don't need to put yourself out any further than that. If they are happy with saying it's malignant, that's good enough for the frozen. If they ask you, oh, well, what do you think it is? Then you can give your impression. And here it is on permanent sections, a high-grade tumor, although it was only 1.1 centimeters. This patient was picked up on screening and is a lucky patient to have their small cell resected. But it could be something else too. So if you look around, this is the same nodule, another area. If you weren't carefully looking to say, oh, I see a mitotic figure here. Oops, sorry. I see a mitotic figure here and maybe here. So, but look at the morphology here. The one thing that you must not confuse a small cell with is a carcinoid. Because for a carcinoid tumor, whether typical or atypical, the resection can be much less than that for a carcinoma. As you know, these are relatively indolent or slower growing tumors, malignancies, although they are all malignant, then the resection will be guided by your frozen diagnosis. So if you don't, one thing I've learned is that if you don't think about it, you don't make the diagnosis. So I would say that anytime you have a lung frozen, the first thing you will think about it, is it benign or malignant? Then the second thing you will think about it is, do they really want to know small cell or non-small? And then the third thing is could it be a carcinoid? Although remember, carcinoid tumors are only maybe 2% of all lung tumors. But since the surgery is so much different, it's a very good differential to keep in your mind all the time. And you can see on this frozen how easy it is to mistake one for the other. Not only on frozen, I think even on a biopsy, an endobronchial or a transbronchial biopsy with the crush artifact, it can be really hard. So for a permanent, I would do a key 67 to differentiate between it. But on a frozen, you are stuck. You do have to use your judgment and say, I can't be sure whether this is a carcinoid or not. Send me more tissue if that's the key. But if you have the whole nodule, you might want to do a touch prep, because I think a touch prep is sometimes easier to show you the morphology and the mitoses in it. But you have to be comfortable looking at touch preps. I personally am not comfortable with cytology because I did not learn it well during my training or even afterwards. And so it's been a difficult for me to do primary diagnoses on touch preps during frozen. I always like to do both the touch prep and a actual tissue section. So you have to do this based on what you think. So the main differential for a small cell would be from a carcinoid tumor, whether typical or atypical. You don't need to make that distinction, but you certainly have to think about it. Okay, so so far what I've emphasized is how to cut into a specimen, what the main differentials are most of the times. And this next case illustrates a different point. This was a 72-year-old male. And, before and a level 7 lymph node is sent for frozen. This one, they basically just need to know whether it's positive or not. But remember, a level 7 lymph node means that it is unresectable before chemoradiation. So they will stop the surgery if you call the lymph node positive, and then they will give the patient chemoradiation, hoping that it will downstage enough for them to resect it. So any mediastinal lymph node, you have to be very careful that you are calling it appropriately. We do understand, of course, that the surgeon understands also that there is 1% or whatever error rate, and they know that. Okay, so here is a case that I think I learned the most from in this setting. This was a 64-year-old female, and there is a history of CLL. A 1.5 centimeter wedge biopsy was entirely submitted for frozen. So in the back of my mind, I'm thinking, okay, this patient is a leukemic. Are they thinking infection? Are they thinking leukemic infiltrates? And this was the section from it. And I saw, and this is my case, so not anybody else's. It is some years ago, but I have not ever forgotten this case. So in the background is all of this scarring. It almost looks like an infarcted tissue that has scarred over, and what are remaining are airways. So as I looked at this, I thought, oh, I can even see maybe some smooth muscle around it. So that's a blood vessel. But is this a bronchiole? They looked very bland. And I looked around a little bit, same sort of a situation, basically scar. And I think I did call it fibrosis or scarring with something. Then when I got the permanent section, and since the whole specimen had been submitted for frozen, that I think makes it a little harder to look at the permanent also from it. But now when you look at it, these cells that are lining it, first of all, are not ciliated, which you can see on frozen section also that they were not ciliated, and that there is nuclear atypia, which is more than what you would expect in a benign lesion. So there is some nuclear atypia, but it is still a rather low-grade lesion. And then as I look around other areas, if you move out and look at this permanent section, there is a large central scar in the upper right, and then there is a proliferation of atypical pneumocytes. It looks rather bland, but you do have to look around at the areas that are more cellular. And there were foci of cells that are crowded. I think nuclear overlap is a very good feature of malignancy, because even on a frozen section, you can see the overlap. And then these very prominent nucleoli. So I went back to the frozen section, the same slide, to see what was it that I could have done differently. So now when you look at this, you can still see that central scar, which is more at the bottom. And then there are some areas which initially I thought were tangential cuts, but they really are piled up epithelium. When you go higher power of them, there is a crowding. So I would say that when there is so much epithelium that you can't really differentiate between, and they all look the same in the different fields, and you can't differentiate or you can't appreciate any cilia, you should really be thinking a carcinoma. Now, in this, here is another area, which originally I dismissed as being a tangential section, but there is nuclear crowding, some atypia, and in retrospect, of course, it is a little bit easier. And so at that time, nothing so bad happened. I think if you're going to make a mistake, it's better to err on the side of benign, because they can always go back and do a lobectomy later, rather than an over-diagnosis. So a little bit caution is all right. But anyway, so well-differentiated adenocarcinoma can be a challenge. Okay, so moving on, how am I doing for time? Oh, good. The next case is a 64-year-old female with right lung nodules. Remember, see the pleural nodules, and a wedge biopsy was sent for frozen. Actually, if there are questions as I go along, if somebody's monitoring the chat or the Q&A, please feel free to ask me and interrupt, because I think it's a better lecture if there is some interaction with the audience. So feel free to ask or comment on anything that you have any question about. All right, so here is the next case. It's a 64-year-old female with right lung nodules, and a wedge biopsy is sent for frozen. So looking at it at lower power, appreciate the airway here in the upper middle portion. It looks very nice, normal, stratified epithelium. A lot of inflammation in the background, lymphocytes, and also a giant cell. I think giant cells are easier to spot than really granulomas. Maybe here that looks like a granuloma adjacent to this blood vessel, but certainly the whole thing looks inflammatory. So if you have a section like this, you can call it just either granulomas or inflammation. And if you look around in the other areas, there were a lot of these meson bodies. So how does one recognize them? They are balls of fibrous tissue within the airways. They tend to stream from airspace to airspace. And most importantly, the inflammatory cells that are outside, you can see some of them even within the meson bodies. So that differentiates it from other areas of fibrosis, like in a fibroblastic focus for usual interstitial pneumonia, although that really in a mass or a nodule is not in the differential. What you do have to remember is that organizing pneumonia can present as a mass. Not always, but it can present as a nodule. And I think for frozen section, that's the most common time when I see it, especially with that history of multiple nodules. Those were, they only biopsied one of them, but the patient was treated medically afterwards and regressed. So organizing pneumonia is a good diagnosis to make for that patient.
Dr. Hussain, there is a question on the chat.
Yes.
Someone asked, how will you call frozen section if you are suspicious for lipidic pattern adenocarcinoma?
Very good. So if you go back to this one, I usually do tell them that invasion, I'm not sure about the invasion, it is carcinoma, as long as the lesion is more than 5 millimeters, because remember, less than that, we are not even calling it carcinoma. It's hard to freeze it. If it's larger than 5 millimeters, and it is only, you don't really see any invasion or acini, you could tell them that on frozen, it is difficult to assess for whether there is invasion or not. But the good thing is that for treatment is the same for adenocarcinoma, whether it is lipidic, all lipidic, or adenocarcinoma in situ. Since these lesions are large enough to be picked up on image and it's being sent to you, this one was what, 1.1 centimeter, that they would have to do a resection anyway. So making that distinction in frozen is not that important, as long as you call it adenocarcinoma. They don't want to know whether it's adenocarcinoma in situ or is it invasive, usually. Okay, good. Okay, so this one was the organizing pneumonia. All right. So the next patient was an 82-year-old female. She has a history of head and neck carcinoma, and a 9 millimeter nodule is sent for frozen. So there is a story behind these two blocks. Generally, you and I would just do one section because it's only 9 millimeters. It's not a very big specimen. It would be perfectly fine to just cut through it and submit one block for frozen. But this is a story that also I always remember, and it makes a great teaching point. This was Dr. Krause's, who's my chief case, and he always has taught everybody that you should look at the specimen yourself. I think that is a lesson that we've all learned well here, because when he looked at that nodule, so the first section was cut and it only showed organizing pneumonia. But he looked at the specimen and he said, this really is a solid nodule. And he's cut and asked the resident to cut one more block from it. And I'll show you how the two blocks look. So here is the first one. There is epithelium or airway on the top right. And below, the lung looks basically inflammatory. There is some fibrosis, some meson body that I think I can recognize here. So there is organizing pneumonia. Oh, here, a higher power showing you very nicely these meson bodies are of organizing pneumonia. But the second block, which he so correctly had them submit, shows a different scenario. Here is lung on the outside. At the periphery, there are a lot of intraalveolar macrophages. There is fibrosis. But within this nodule is an area that looks like cancer. So this was a metastasis of the patient's head and neck, or we think is a metastasis from the patient's head and neck cancer. But remember, you cannot tell that apart on frozen section. All they wanted to know was whether this was benign or malignant. And so sampling is very key. I think when we make a mistake, it's not really a mistake, I guess, but we all have done frozen sections in which your frozen section is benign, but other sections that were not submitted for frozen turn out to be malignant from a specimen. So to avoid that, if you look at the nodules and you really think that grossly it looks suspicious and is very firm, yellowish white with the characteristics, even though it is small, I think submitting more than one section would be indicated. So adequate sampling is the point I want you to make with this case. Okay. So now I'm going to move on to pleural biopsies. But so far, that was my take on nodules of the lung. If there are any questions about any nodules, I'm happy to answer those now.
There was one question about case 2.
Okay.
So someone asked, wasn't that frozen section on the needle core biopsy and case 2 a touch prep?
No, that was an actual section. So actually, let me go back to the case 2. You could have done a touch prep if you were comfortable with it, but this is an actual section of it.
Okay, and there was one more comment. Since many times surgeons have unrealistic expectations from pathologists, I was wondering whether you presented this talk to surgeons as well.
I do. So, that happens to me all the time. It is, it's doing that thing. And now I know how to do this. Okay. So I think what has happened to me over time is, I think, one, I've gained experience and a little bit more authority with the clinicians. When you are fresh out of fellowship and you're calling a frozen, your surgeons are not going to be very accommodating, but they are demanding. And the way I've dealt with it over the years is, as I said earlier, that during the frozen section, when they are in the OR dealing with the patient, you don't know what's going on in there. Is the patient bleeding? Is it whatever? I don't argue with them at all. I give them the answer they want, or I will do a frozen section and give them my best judgment. If I have to defer it, I will tell them, I need more tissue, or I need, this has to be deferred for the permanent, or you can get a consultation. That works really well. Even if the other pathologist is not a thoracic pathologist, not for that, it works for every specimen actually. If that other pathologist is not the same specialty, but at least 2 of you have looked at it, I think it carries more weight with them and say, this person is available for consultation. I had them come over and look. We both cannot decide what it is, especially, things, difficult ones. They will be all right with it. You just have to stand your ground somewhat. Does that answer your question? There are other things they will do. So they will do things like they'll send you a frozen and then they'll say, oh, can you send for culture? And you have not maintained sterility. So in that situation, I tell them that and I'll say, okay, if you've only made one cut through it, you can try and open a sterile blade, try and get some more. I will send it, but who knows what the results will be.
Okay, and then one more question. someone asked, increasingly surgeons send very small nodules, difficult balance between making a diagnosis on frozen and saving enough tissue for permanent molecular testing, strata, etc. Any helpful hints or comments?
Yes. So the first, I usually at tumor boards have already had these discussions with my surgeons over time and said, if it's a really small nodule, what are you going to do that's different? If it's less than 5 millimeters, I will not freeze it, because those are incidental findings. Unless it's widely metastatic, like little nodules everywhere, and they just want a diagnosis. So depending on the clinical setting, if it's a single nodule, 5-6 millimeters, I say this needs to go for permanent, that there's nothing you can do right now. Between 7, 8, 9 millimeters or a centimeter, you have to use your judgment. Just make sure you submit only half of it, because you could cut it half, or if you're comfortable with cytology, do a touch prep. But I will do a section, because I'm not comfortable with cytology enough to call it based on that. You may want to ask your cytopathologist to come help you if that's the case. But I think asking them that say that I've cut into the wedge, all I have find is this small nodule. Do you still want me to do a frozen, or because it will then compromise the permanent? But with all the immunohistochemistries that we have now for permanence, I think making a diagnosis even on a previously frozen specimen for lung especially is not so bad. I think, if it's really going to change, if they say, oh, we are going to do a lobectomy if you call this malignant, then go ahead and do it. I've even frozen the whole of it and said, okay, that's what they want. It's for patient management, so we shall see. Yeah. I know, not always easy.
So one more, is presence of cilia enough to call a lesion benign?
Yes, cilia in the lung, it is so rare to have a ciliated carcinoma. I know I've had this discussion with other people that apparently there is a ciliated carcinoma in the ovary and other places. In the lung, I think there might have been a case report of it, but really, if you find the terminal bar and a row of cilia coming off of it in more than one or two, like 2 or 3 different areas, I call it benign, just based on that. But obviously the morphology fits also, but sometimes it's just the cilia, because I don't think that ciliated carcinoma really is, it's like a 1 in a million cancer. I wouldn't worry about that. I think on a frozen section, if you're using cilia to call it benign, it's a very, very good decision.
Thank you.
Okay. So now onto the pleural biopsies. Okay. So the clinical history is really key. So notice here that this is a spontaneous pneumothorax. And the patient is undergoing this video-assisted surgery to just repair that, and they do a pleural biopsy. But they're asking the question, could this be mesothelioma? Because when they went in, they saw thickening in a lesion that they think could be. Now, this, I think, is a really tough proposition to try and decide that on a frozen section, because what are they going to do differently? They're not going to resect the pleura. You could have asked for more tissue. If you don't have enough, you can always ask for more tissue. But the point I want to make here is that there is a proliferation of what are presumably mesothelial cells at the top. They seem to end right where this connective tissue is. What's at the bottom are lymphocytes and maybe some macrophages or plasma cells, whatever, but essentially mononuclear cells in the bottom. So there is a sort of a layering with the mesothelial cells at the top, maybe some fibrosis and chronic inflammation, not really invasion. But during frozen section, looking at anything at too high a power, I think is a problem. Because to my eye, when you go high power, so many of these reactive mesothelial cells look malignant because they do have prominent nucleoli. Their nuclear membranes, here's maybe a multinucleated cell. Their nuclear membranes don't look that smooth. Look at this one, how irregular it looks. And I don't know that I can be 100% sure one way or the other. So here is another area from the same biopsy. Look how atypical these nuclei look. There's some gigantic nucleoli, also multiple nucleoli, which are, and the nucleoli are also irregular, which is, to my book, I always was taught that that meant that this was going to be malignant, but not always. So remember that mesothelial cells can be very reactive. And in this case, I think we said we cannot really tell you whether it is or it isn't. We'll have to rule out a mesothelioma on permanent, and they were okay with it because they were basically in there to repair the pneumothorax. And so on permanent, there were even more inflammatory cells, and then there was that layering, no invasion was seen, and we did call it fibrosis, inflammation, and mesothelial hyperplasia. So I want to show you another view, another case from my collection in which there is this non-invasive sort of superficial proliferation. So one thing that I find is helpful in mesothelial lesions is that if there is no invasion, don't call it malignant, especially on a frozen section. On a permanent, mesothelioma in situ is now an entity and we can stain for it and look for it. But during a frozen section, you can say, I see no invasive tumor. They are not going to ask you, is this mesothelioma in situ? So when the mesothelial cells stop at the top, that's a good thing. All this inflammation in the background and this kind of layering, mesothelial cells in one area, lymphocytes and fibrosis in another area, that's a good sign of benign. So I've listed, oh, it's coming up. I've listed the differences between how I differentiate between mesothelial lesions and benign and malignant, and we'll talk about those. So this is another pleural biopsy. And here the situation is very different from what we see before. In the previous one, all the mesothelial cells were like in one nice group. There weren't that many of them. But here, see how much there is? Even if you don't see any invasion, if you have extensive tumor, call it malignant, because no benign reactive mesothelial proliferation will be quite so exuberant or so much of it. Even though cytologically, this is similar to what we saw before, the nuclei, mesotheliomas can be pretty bland, and you don't see that much atypia as you do in carcinoma. This is from a permanent section. If you were to see this on frozen section, that the tumor is infiltrating into the fat, then it's easy to call it malignant. Also, if you see lots of tumor necrosis, it has to be truly tumor necrosis to call it, not just fibrin that the cells are embedded in. That benign mesothelial lesions will not have necrosis. This is clearly tumor cells, nuclei in it. This also is from a permanent, so I didn't really have a frozen section to show these 2 points in. But so basically, if there is layering of non-invasive cells, then that's benign. And any invasion has to be malignant, especially if it's clearly into skeletal muscle, and not just a floater of your knife carrying some cells into it. If there are large amount of cells, call it likely that malignant. Okay, so that was it for the tumors of the lung and pleura. I'm going to move on to evaluating immunocompromised patients, because I think that is a key difference in when you're thinking malignant and then when you're thinking something else. I really encourage our team to send frozen sections because infections can be diagnosed on frozen section. This happens to be a nasal polyp, but it would be the same if this was a lung. I didn't have an easy photograph of one, but this one clearly shows you fungal hyphae growing into the tissue. If you cut a thick section and overstain it with hematoxylin, I think the fungus really stands out well. So on a very thin, so I think a 3 or 4 micron section is too thin for frozens. We set our microtome at 5 microns, and sometimes I think 6 microns might even be better to see these, but fungal hyphae can be seen on frozen sections. It's just like you can see them on H&E, because basically you're staining them H&E. So immunocompromised patient, fungal hyphae. The only fungus you cannot see is PCP and histoplasma, but that would be an unusual presentation for a frozen. The hyphae, the fungal with the hyphae present as a mass, and they might want to know if this is, the differential is between, usually if it's a lung biopsy, PTLD and fungus, or fungus and viral infections. Okay, so you have to think about fungus in the immunocompromised. Another lesson that I learned from this particular case, this was a 4-year-old with a treated leukemia who presented with lung infiltrates. The patient did have some massive infiltrates. And this sort of, what this taught me is that what you don't know or what you don't think of, you cannot make a diagnosis. So this was the touch point. So finally I did have a cytology. I looked at it and I said, there is this granular material. I really don't know what it is. And then I looked at the frozen section. And this one is one that I should have submitted more tissue in, but I didn't. So here is another specimen that I learned a lot from. So I look at this section and I say, there is some edema. This patient is a leukemic patient, has been treated, so who knows, is in heart failure, what it is. And so I just called it some reactive inflammatory something. And this is what the permanent showed. So on the permanent, you can clearly say that this is this proteinaceous material, and this was secondary alveolar proteinosis. So going back one, that apparently for the cytologist is key. This is what they see in PAP, but I just had never seen it before on cytology, so I didn't know what this was. Neither had I ever seen this on frozen section, so I couldn't interpret it. But that's the only case that I've actually ever had of PAP. So, but there is another moral to this story, which is that knowing the clinical scenario before you do the frozen sometimes is very, very helpful. So if this was the image that they were going after, they did a frozen off. And if I had thought about looking at it, there are big masses here. And that was what I was calling edema, didn't account for it. So what had happened was that when this resin got the frozen, and I shouldn't really blame the resin, they did the right thing, I would think. But anyway, there was an area of infarct in it. And, we all learned that don't freeze tissue that looks necrotic. You need to freeze more viable looking tissue. In this particular case, that didn't work for us well because we completely missed this area within the necrosis, which here you can see a thrombosed vessel. And within these things in cross section are fungal hyphae. You can actually see them growing out. Let's see if you go here, higher power. On the permanent, on H&E, they're easy to see. So there are times when even freezing the necrotic portion is indicated. So if your frozen section diagnosis doesn't fit the clinical picture, look at that specimen and freeze some more sections, is what I would say. And here is the GMS showing you that massive fungus. Other things that in immunocompromised patients, here is a post-lung transplant that you should be suspicious for, is when the nuclei are larger and smudged. You may think that this could be a viral infection. You can suggest it so that they can, you can expedite, or they can look for it in antibodies in the serum, or the viral load in the blood. So CMV, they're monitoring in these patients. It's easy to see. And so is EBV, that load they're monitoring. If those are high, then you can be more confident in your diagnosis. But if you don't know those, you can suggest that there are some reactive looking cells in here, may be suspicious for a viral inclusion. And this one turned out to be adenovirus. Here is an immunohistochemical stain eventually that showed positive, but CMV can also be diagnosed on frozen section because the inclusions are quite characteristic and can be seen. And you have to be thinking about it.
Dr. Hussain, one quick question. Would you speciate the fungus on frozen section?
Oh, no, I wouldn't. Thank you for that question. I actually don't speciate the fungus. I do tell them whether it's hyphae or yeast forms. And if you can see septate, then yes, because on frozen, they're really not going to do anything different except starting it. They may guide the culture or whatever else, but speciating on frozen is not a good idea. Even speciating on a permanent, I usually tell them this is in this group of things, but however, correlate with culture, because I've made mistakes too many times. I've called something Candida and it turns out something else, or I've called it Aspergillus and it turns out something else. You just suggest something in a comment. I never put it on a line diagnosis as to what fungus I think it is, except for, clearly things like histoplasmosis, you can tell, PCP, you can tell, blasto often, but not always, cryptococcus, you may be able to say, but I think these fungal hyphae, it's better not to. All right, so moving on to the last couple of cases, a mediastinal mass. I don't have a very good picture, high power, but the low power says it all. When you see these, if you know it's a mediastinal mass, your differential is of course different. Obviously, lung cancer can still be so big in the mediastinum, or they don't really can differentiate a central tumor from mediastinum. You can always have lung cancer present like this, but what you should really be thinking of is it thymic in origin, because if you are going to make a diagnosis of thymoma or thymic carcinoma, I mean, thymic carcinoma is much less common, but you don't have to really differentiate between them if you can say it's thymic in origin, because that will lead them to a resection. Because thymic tumors, irrespective of what they do best if they are resectable. The one pitfall is that lymphomas can also have this fibrous bands, and you have to make sure that you're, whether it's a lymphoma or a thymoma. And that can be a tricky frozen section. You do have to find some epithelial cells, maybe a touch prep would be more helpful, maybe at other sections and looking around to see when you have this lobulated sort of fibrous septa in it, that's your main differential is from a thymoma or thymic tumor versus a lymphoma. And so think about that and make your call up accordingly. Okay, and then lastly, the 60-year-old male with a chest wall nodule. Here it's clearly malignant going in. You appreciate the tumor within the fibrous tissue. Sometimes the metastases are easy, but if you don't know, this is a patient that had a thymic carcinoma in the past. So knowing the history of what it is important. If you don't know, and or the patient, you're really busy and you haven't thought about it, if you had only called this malignant, that would be fine too. It's then up to them to say, is it resectable or not? But this happened to be a patient that was thymic. So to summarize, I want to say that the one thing that I've learned is that you must know the clinical setting and what is the question the surgeon is asking. And then everything else follows. For any organ system, you would say, you would consider, is the patient immunocompromised? Are you looking for an infection? Are you looking for, how would you sample it? How much sampling do you need? Usually, many times one block is enough for frozen, but many times it's not. You might need to put in more than one block. Use your judgment on that. How to cut it and how to stain it. I think that also takes some, how thick should the specimen section be? My personal bias is that 5 micron thickness of the section is ideal. Less than that, you can miss nuclear details. It's too thin and malignancy is difficult to pick out, especially in a lymph node. And thicker than that, interpretation can be difficult, but if you're looking for fungus, 6 microns is also fine. Sometimes you need to overstain, especially if it's a fungal infection. If it's an immunocompromised patient, you might need to really stain it very well. And then, of course, communication. You must talk to your surgeons in different times. I think all of us now are practicing in settings where tumor boards are routine. It didn't used to be, when I was a resident, we only had one tumor board for all the organ systems once a week. That was when I was at Loyola. And they would only present like 2 or 3 cases that were of interest to them, and the pathologist would get up and show it. So there was not that opportunity to develop a relationship with the surgeon. But now I think in this day and age, they know how important tissue triage is, what you're going to do with it. And I think the surgeons are also better educated, and they know what we can tell them and what we cannot tell them. Also, what I find is very helpful is if you volunteer to do conferences for them, teaching conferences, it depends on what setting you are in. Maybe what you could set up is, say, maybe every 3 months or 6 months, say, I'm going to review some interesting frozen sections that you have had and some questions, and have like a little teaching session with them, with the surgeons. That is really helpful, and especially the fellows. So I have ongoing lectures and sessions with the cardiologists and the pulmonary people, which is outside of the tumor boards, so that we can talk about issues that come up. And also they need to understand that they have to provide us the history. It's not that they want us to know what, it's like a game that they are playing, which still, it's amazing how many surgeons still think that if they already tell us what it is, then we will be biased, that they want our unbiased opinion. It's like the example you have to give them is, are you going to have a radiologist give you a diagnosis that you're going to treat based on without telling them what's going on with the patient? So it's the same settings. If they really are going to make a decision on your diagnosis, then they have to give you the clinical information. And you have to have this back and forth and establish a relationship with them. That I think is key. So with that, I would like to entertain any questions or discussions or your experiences. We only have a few minutes left.
Thank you, Dr. Hussain. This was great. There are some additional questions coming.
Okay.
One is, would you do any stain other than H&E at frozen section time for fungus?
Very good question. So what I have found is that if you do a Giemsa, the fungus is sometimes easier to see. We've actually even found AFB or MAI in a patient on a lymph node, which was chock full of MAI on a Giemsa stain. So I'm not that comfortable using a Giemsa all the time, but if you do it in addition to the H&E, sometimes the fungus is easier to see.
Thank you. Next question is for thymoma versus lymphoma differential diagnosis. If ample tissue present, is it reasonable to reserve tissue for flow cytometry?
Oh, obviously. If you are thinking it's a thymoma, well, I think reserving tissue for flow is a good idea, although we know that IHCs and other things can be very helpful in making these diagnoses. But if typically, my experience has been that if they're in the mediastinum with a mass, there will be enough tissue for you to do. You can always ask them for one more piece for flow cytometry if lymphoma is high. Consulting with the heme people and doing touch preps would be key to differentiate between a thymoma and a lymphoma. And definitely, yeah, keep tissue for flow.
Thank you. There is another question. Someone said, we usually have problems for molecular testing. Sometimes there is sufficient tumor, but not enough DNA, especially in hollow organs like lung or GI tract. Any recommendation?
Yes. So what we have found is that if you do touch preps, that's a whole, and air dry them and keep them. We do it 2 or 3. We have started doing them even on rows. That are preferred specimen now for NGS, and we do a 1200 panel, 1200 gene panel in our OncoPlus, that the cytology specimen yields higher DNA because the nuclei are intact. And if you have a tumor, say 1 or 2 centimeters, I mean, less than 1 centimeter, they really don't need that much molecular. But greater than that, if you have like a 2 or 3 centimeter tumor and you're worried about it, or if you are only getting a biopsy because the patient has metastatic disease, making touch preps from those is a good idea, and saving them. We don't cover slip it. You air dry them and you can do a Giemsa stain for adequacy, but you put them aside. We label them for molecular and we keep them aside, and they work well. But you'd have to know from your institution of where you are sending it. Some people have not developed as good a methodology for doing molecular off of cytology specimens. But our place, luckily, the cytologists have been great in setting it up.
Thank you. There's another question. In your experience, for chronic diffuse lung disease, is there any role for frozen section? And if there is, how do you triage it?
Yes, so I do get that. That's a very good question. So the patients who have chronic interstitial lung diseases are at high risk of developing malignancies. So I have done frozen sections in a patient before they went to transplant and found malignancy. Then they have to tell you exactly what they're doing. To make a primary diagnosis, sometimes that is difficult. If the patient does have a nodule, you can tell them it looks fibrotic, but you don't have to go any further than that. Or it looks like fibrosis, or it looks granulomatous, because then they want to know. The other question they ask is there superimposed infection in that patient? And they have not been able to get an adequate specimen, and they want to do a frozen section to ask, and then you can say, I see granulomas in addition to it or not. So that should be an easy enough. So either for malignancy or for infection, those are the two times. Otherwise, to actually make a diagnosis of interstitial lung disease, I don't do that on frozen sections, right? And I don't know that it can be done.
Okay, thank you. And one more question. Do you see any role for frozen section of the small tumors with Thora for clinical team to decide if it's a lobectomy or which?
Yes. So if the patient's clinical scenario is so bad that a lobectomy would not be possible, they already know that. So if they're going to do a wedge on a small or a trisegmentectomy, that's what they will do because they're limited. So how small a tumor will they do a resection for? I think anything less than 7 or 8 millimeters, a segmentectomy is fine. Although there is now, the latest data is showing that patients with borderline, like 1 centimeter tumors that they've done trisegmentectomy on, there is a higher risk of local recurrence. And so our surgeons are now starting to go away from doing segmentectomy unless the patient cannot absolutely tolerate a lobectomy. So in that setting, as long as you can tell them benign or malignant, they can do, and if that's all they're going to do, that's what the discussion should be at tumor board before the patient goes to surgery.
Okay, thank you. So there is another question. Can a needle biopsy produce artifacts that can look like pleural invasion on resection?
Yes. So if they've done a needle biopsy and a track, there's actually been a lot of discussion recently about whether a needle biopsy can seed the lung cancer into the chest wall. Because there was a study out of a recent study that's been published that shows that patients who have undergone needle biopsies get more chest wall recurrences. So they're proposing that there's been tracking, but our surgeons feel that that is not true. When there's been a core needle biopsy, if the tumor is that close, there is fibrosis and hemorrhage and whatever, that I can see a needle track in the resection specimen. You have to be really careful around the needle track. I think usually the resections follow pretty quickly within like 2 or 3 weeks of the needle biopsy. So it's not that there will be time for the tumor to really grow up and into the pleura that quickly, because they're usually not that fast growing. So I think, and the needle core is really only going through 1 or 2 millimeters of it. So if you have a nice big section, I would submit more sections, maybe everything that's close to the pleura, to make sure that it's not due to the needle track. But the artifact can occur for sure.
Okay. Another question, pulmonary enteric adenocarcinoma versus metastatic colorectal carcinoma. Any comments for diagnosis on frozen?
I have that problem all the time. If it really looks colonic with the pseudostratification, with the tall nuclei and the central necrosis, I will tell, and there's no central fibrosis, I will tell them that I favor metastases, but it's always favor. And they know that it's not 100%, because that is a difficult time. And I've had that happen to me before. I had a patient with an endometrial tumor, history of an endometrial carcinoma, and a lung cancer and a lung nodule that was rounded and had morules in it of what squamous, an adenocarcinoma with squamous morules. I looked at it and I said, of course, this is a mat. I even showed it around here. And lo and behold, when the permanent came and we did the immunos, it was TTF1 positive. So you can never be 100%. You have to remember that, and you need to be a little bit more careful. And surgeons they always say, oh, you pathologists cannot make up your mind. You always want to be sure. We have to make a decision now what to do, and here you are not telling us what it is. And so you can say, to the best of my ability, the morphologically, it is consistent with it, but I'm only going to be right 95% of the time, not 100%. So as long as you explain to them that there's no morphologic way of telling them. The other problem comes from like a head and neck primary and a lung squamous cell. There is no way of telling them apart unless you do molecular on the two areas and compare them eventually. So that's also a common question, not as much of colon cancer, but more of head and neck primary. And then they're saying, is it, because the risk factors are the same. Is it a new primary? Should they do a lobectomy or do they just, not easy.
Thank you. There is another question. Does making a diagnosis of visceral pleural invasion on frozen have any immediate implications for surgical management?
No, they would not. They don't need you to stage it at all. They should not be asking for staging on because the surgery is no different. If this is just into the pleural or even through the elastic, if there's obvious spread on the surface with a pleural effusion and cytology has been positive with the pleural effusion, then that tumor is, of course, unresectable. So except for that scenario, which I actually have not encountered on a frozen, because by the time the tumor is that advanced, it really is unresectable based on its size and what it's invading. And I think it's obvious on imaging that the pleura is involved, because you can have adenocarcinomas that sort of spread along the surface of the pleura.
Great. And I guess the last one is a comment. Surgery residents across the country should all rotate through pathology for a month or two to understand what pathology can or can't do for them.
I do. I agree with that. I actually think all medical students should rotate through pathology. So every physician kind of knows what we do. They think they just send it off into this black box and an answer comes back. We do encourage, so if any of you, whoever is in a teaching institution, when you are giving pathology lectures, I always make it a point to tell them some clinical story. Here is a biopsy, and this is what the cardiologist thought or the pulmonologist thought, and this is why I'm doing it, and this is what I do all my time. I look at biopsy. They think all we do is our autopsies and whatever. It's the medical students don't understand exactly what we do either. So we have to be advocates for our practice, for sure. Yeah. And we used to, before things got so complicated, we used to have both surgical, especially surgical oncology fellows and gynae fellows rotate with us. But, the pressures on them are also great. They are not coming anymore. It's not required rotation anymore, anywhere that I know of. Yeah.
Okay, thank you so much, Dr. Hussain. This was great. If anybody wants to claim CME, the link is on the chat, so you can click on the link and claim CME. Thank you very much. We see you in a couple of months.
Okay, thank you.
Alrighty, thanks. Okay, it went well.
Thank you. I was trying to watch the time and make sure. I tend to talk too much sometimes.
No, it's okay. So a lot of times it goes 5 to 10 minutes after. So thank you for staying late.
Yes, of course.
Yeah.
Yeah.
It was good. There were a lot of questions.
I'm glad. This is